We checked Dr. Garner beforehand. He has a 2-inch leg deficiency. He's completely out of alignment. He's going to stand here and show you. Okay? Right shoulder, high ear, pelvis tilted, foot flared out. He's a mess. All right. Immediately, in one visit, we're going to change his structure. Okay? Please face down. Dr. Garner. Back surgery 6 weeks ago, so I'm sure didn't want to. Okay, and we have Dr. Roger Smith. Okay, so we have Dr. Garner. This way, put his heels together. Okay, I need a close-up of that, Jerry. Got a close-up? Mm-hmm. All right. Dr. Garner, turn your head to the right. No movement. Turn your head left. No movement. Face down. It's a negative deer field. When he turned his skull right and left, the pelvis did not shift abnormally, so the leg lengths did not change. Now, I'm going to start dropping his feet. Okay, and right here, the leg length's even. See that, Jerry? Okay, and when I go here, the leg lengths shift again. We eliminated the occiput, so the problem is in the pelvis, hips, whatever. We got to try to find it. So let me check the feet. Dorsiflexion of both feet. Okay, fairly normal. Left Achilles tendon, taut. Right Achilles tendon, 20 degrees tauter. Is it tender when I squeeze it?
Yes.
Is it tender when I squeeze it?
Mm-hmm.
Okay, athletes. Okay, he's got a thick Achilles tendon on the right. Okay? He's got a thinner Achilles tendon on the left. So if you're an athlete, I don't care what kind, you got pressure right here from the muscles, soleus, gastrocnemius, digitorum longus, coming down, attaching to this tendon. This is going to tear. This is a matter of time. The athletes we take care of, okay, like you see on the wall here, they come in twice a week or more like we tell them, or we won't take care of them. And we keep them balanced, so we relatively eliminate these non-traumatic injuries where they're taking a step and running, okay, and all of a sudden they tear Achilles tendon. That's ridiculous. That's never supposed to happen, right? Okay, so this is telling me that a foot's out of alignment. All right, I see his pant line, and his pant line's deviated to the right. I put my hand on his pelvis, got a glute, no glute. Gee, you better exercise that glute because it's really flat here. Well, doctor, if my pelvis is way shifted and my ischium's down, would my glute go with the pelvis and be flatter because it's an anterior rotation of the pelvis? Very smart. You're a very smart patient. I don't know, maybe. Let's see. All right? So, we go right ischium, left ischium. Ischium. High on the left, low on the right. Pelvis, low, high. Okay? Let's just see what else is happening. Let's go to the second sacral. Excuse me, Doc. Okay? Any pain? Okay, second sacral, good. Let's go to L5S1.
A little bit.
A little bit, okay? Spinous process only. Okay? Anything?
No.
Anything?
No.
I love his lumbar spine. At least in sacrum. I press S2, L5, S1. Now let's go to L5 on the left.
No.
No? And on L5 on the right?
No.
No. So lumbar spine, test fine. This is a sacroiliac pelvic problem. Right? And he's taking care of himself where, at least at this point, it hasn't gone and caused symptomology in his low back. He's young and strong though. Now let's check the occiput. Okay, left occiput, right occiput. Interesting. Left occiput, posterior, superior. Right occiput, interior, inferior. All right? His head ain't on straight. Let's see something. And I can do some of these, but Dr. Voytecek or Dr. Smith will do some other ones because I can't hurt myself. All right, so I want you to turn, and remember we have this. Okay? The 1.5 to 2-inch shortness, right? And so, I'm taking care of doctor. I'm like, I gotta come up with the smartest thing following the pattern. Well, I started the pattern with my feet and I find a few things and I don't find a few things. So he has different problems. So I want the low occiput to be up. Turn your head to the right. So this is the low inferior occiput. Okay? Lloyd table. Thank you. Dr. Jancy, Desjardins, Fred Illy, numerous ones. The communication between the occiput and the sacrum. The communication between the occiput and the sacrum, magical. If you free the occiput, you free the sacrum. They talk to each other. Brain, brain. And if you do that, sometimes with this certain type of specific accurate correction, you open up everything and the sacrum and the occiput end up realigning the vertebra in the spine. So, okay, did it drop?
Yeah, it dropped.
All right, face down. We say abracadabra. You got to have the magic words. And then when you do this, okay, and now we have perfectly even leg lengths, no deficiency. Well, wait a minute, Dr. Vetanze, you checked that earlier and it didn't show up. Well, no it didn't. Maybe the occiput wasn't jammed to the point where when I did the previous test of turning the head right and left, it changed the pelvis. It didn't change the legs, but it was still there. But interestingly enough, now that I fixed it, it fixed the leg deficiency. So let's stress him up here. Okay. Okay, and go back. Okay, and this isn't trickery. I'm not like putting the feet, doctor, you're watching this, doctor. I'm trying to be as consistent as possible. Dr. Kimball, right? All right. So, I'm happy with that. Now that I got that lined up, what happened to the pant line? No. He's got a butt. In this particular case, I adjusted the occiput, I adjusted the sacrum, haven't done anything else, pelvis shifted. Because now, he's not anterior on the right side. The legs shifted, the short leg went away on the left side. That means the pelvis had to move. Okay? The sacrum and occiput are communicating. Now, the pelvis looks good. Ischiums, and now we have a high ischium on the right and a low ischium on the left. Now we still have a foot problem. This is where it all started. So using a speeder board, okay, watch the arch. I'm stretching that pretty hard, isn't I, Dr. Garner?
Mm-hmm.
Okay, I'm trying to get that arch to flex. Right here. You see the folds in the feet. Nah. He's not firing on his right foot. If you're an athlete, you ain't firing on your foot, you're not as much of an athlete as you could be. You're actually using your whole foot to walk and you're looping. Many of these players come in here, Dr. Smith, Dr. Voytecek and I will look at them, we can see how they walk, we can tell them exactly what the problem is. Let's go to this foot. See the folds in the feet?
That hurts.
Your hip or your foot?
Foot.
Okay. But he's got good movement. Was it hurting your arch or your heel?
Actually on the dorsal surface.
Up here?
Yeah.
Talus, at the talus bone.
Yeah.
See, he has a talus bone here and he has a navicular over here. That's another thing, we'll show you that in a second, right? All right. So we want to do the feet and the pelvis for me?
Yes.
And explain.
So without the foot movement, we're going to tap the navicular into place so that it can slide and get that motion. So just that little tap, see how his foot's folded now? We're getting that range of motion. Incidentally, this gastroc calmed down, and this thickness and tightness, that feel a lot better, Doc?
Yeah, it doesn't hurt at all.
Yeah, that should be
So
gone.
we squeezed that tendon, and it was really painful. He actually lifted his head off the table. Now it doesn't hurt. By putting the navicular back in place and then putting the calcaneus back in place, you change the length of the gastroc and its tendon, Achilles tendon, which takes the pressure off of it. Tell me what you're doing.
So after this, I know Doc had a left short to start, but it's a little slight right short. So it shifted. When we adjust the navicular, that too is attached to the brain, sacrum. So it shifted, the proprioceptors to the foot shift how the body is in space. So he's got a high left ischium and a low right. So we're going to shift that ischium for him. Assisted drop to shift that pelvis.
Assisted drop. Never push on the patient to start to drop, chiropractors. You should start to drop with some part of your body, sitting or your leg. Have the table drop and you're tapping at the end. You don't have fractures that way. We'll show you a little technique where you don't tear vertebral arteries anymore also.
Doc, go ahead and flip over. I'll move that talus.
And now the talus is how the other foot corresponded because of the bad right foot.
So left foot
Left foot.
flexes, right foot here flexes quite nicely. Left foot, I don't know if you guys can see it, it's like hitting the wall.
Get a close up, Jerry.
It's,
Okay, he's swollen in here,
and it's not moving.
or there's an object here.
So if you compare them side by side.
Two
this
different
one-
ankles.
Totally, this is not going. So we're gonna just slide this talus down into his foot where it belongs. And now, it's flexing. So when I do, remember how he had pain in the front when we were doing his foot?
It's gone.
Is that gone now?
It's gone.
And there's nothing here either.
Calcaneus is okay?
Yeah, both of them are.
Okay. Did you check the hips for me while you're at it?
Left hip internal rotation's about 20 degrees.
Any pain?
Yeah, end
It's
range.
tight.
Okay, pain at end point. And we had to stop at 20.
Right one. What the fuck? Hard for me to see when I'm in the way. I get it. Right one's more 45 degrees. Any pain at the end point?
Now let's talk about end point just 1 second. Okay, we do hip, this is internal rotation of the hip. We're trying to see how the head of the femur is sitting into the acetabulum on either side. Okay, when he did this internal rotation, I could tell there was an immediate stop.
Correct.
Okay, it was bone to, so the head of the femur is hitting the wall of the acetabulum and stopping. All right, that's bone to bone. When he did this one, it was tight, but you felt a rubber band bouncy effect. That's not bone to bone. So it's two different types of restriction, and internal rotation designate two different things. There might be more, but this is what I discovered. This is bone to bone, right here.
So we're going to move left hip with the assisted drop. And we're also going, during this movement, we pull the pubic symphysis with it. I know you docs, I know everybody knows that there's 3 joints in the pelvis. We address all 3 of those with this GPA method.
Yeah, good idea.
Good idea. Drop your leg out. Again, it's assisted drop. Just tapping it in. There it is.
Okay, this setting, he's setting the table patients with his knee. Just that it's a tap. We didn't barely felt it, right?
No.
It's a tap. Okay. And now,
This is 45 degrees, almost 50. Is the pain gone at the end?
Gone.
The end range, we're not hitting that wall anymore. We're not hitting the
and you
acetabulum.
see right now. Let me have it. Let me have it. Okay. Where was that?
Knee.
His knee just clunked, and I felt it way down here in my left thumb. The fibula just adjusted. Yeah.
Self-adjusted.
Yeah, self-adjusted. Okay, so let me have it, doctor. All right. So now when I do here, feel that little rubber band bounce?
There's no pain.
There's no pain. So adjusting the pubic bone shifted the acetabulum, head of the femur went back where it belongs. How do you know where it belongs? I don't have to. His body knows where it belongs. We just have to create the alignment so it can normalize and fix itself. But now, it's even getting more. We're like 60, 65 degrees here in internal rotation. That's a completely different hip. Yeah, and?
So on the opposite side, without even doing anything, he went to that 65 degrees because the body set the whole pelvis and it wants to have balance.
Can I ask a question?
Please.
So when you're doing these drop table adjustments, you're applying a force to a specific joint. Is there a, pardon me for the dumb question, is there a rhyme or reason to the vector of that force? Is it orthogonal to the normal action of the joint? Is it parallel to the joint? For example, SI joint, right? It's oblique.
Correct.
And then your pubis is vertical, right? But it's got some, the range of motion is not, it doesn't necessarily, it's not unidirectional. So when you're, and I'll just say as I'm watching this happen, it kind of feels like there's a reset happening when you're, pulling on the foot and dropping the foot. You're doing a drop adjustment on the foot with that, what's that board called?
Speeder board.
Speeder board, right? It's similar to what you're doing here. But when you're applying that force, it's like, it feels to me or looks to me like it's kind of allowing the joint to reset where
You're
it
absolutely
wants
correct.
to be, right?
We are setting the,
Absolutely.
setting the joint, and our method is to follow the plane of the joint, even though it looks like we're just going one direction. So that adjustment that I did follows that oblique SI joint angle through the pelvis.
Got it.
Even though I'm working on the front of his hip.
Yeah. We would never go against the lines of articulation. We try to go with it.
So if the SI joint is like this, do you want that force to be going this way? Do you want it to be going along the joint line?
Well,
Along the joint line.
along the joint line, there might be.
So it's kind of
Certain
creating this
Yes.
this
Yes.
motion, right? Even though that joint can do this too, and it can do this as well. It doesn't do much, we know that. But you're trying to allow it to.
Correct itself.
You're saying it's subluxed,
Yes.
malaligned,
Malaligned.
and then you're gonna try to get it. I mean that sounds simple for you guys, but for a surgeon, what is really happening? What are you doing? How is that changing the joint on a micro level, 1-2 mil, whatever it is? That's what
Symmetry.
I'm trying to understand.
Symmetry.
Yeah.
We're trying to create symmetry
Yeah.
along the joint articulations. Yeah.
Free up a fixation. Free up a fixation.
Yeah. Free
Yeah,
up a
a
fixation.
fixation.
Free it up. We use balance everything. But we try not to start at the pelt. We want to fix below it first. Now you brought up something interesting. With the joints, okay, we rarely do side posture or lumbar adjustments. You see all these advertisements with chiropractor, have you laying your side, bam! Bumble bum, Jancy said, bumble bum. Backward, upward, medial, backward, lateral, backward, medial. The facets of the cervical, of the spine, cervical, thoracic, and lumbar, right? The old national thing, bumble bum, which means backward and medial. So if you have facets in the low back that are backward and medial, all right, and you lay somebody on their side and you put them in a certain position and you crunch them, how do you know what you're doing to the facet? It scares the hell out of me. Now, if you want to, we do it, but if you want to stretch them, pass and then stretch them and let the vertebra go by itself, but we can't get the specificity. Sorry, chiropractors. Maybe I'm not good enough in side posture. I can get the specificity of moving a particular vertebra the right way by laying them on their side and involving a whole series of vertebrae. I don't know what my outcome will be. I will stretch them that way. I'll line them up a little bit if I can't do anything else easily, but I don't want to do a correction that way. Let's get your sacroiliac, lay here on your side. No, I'm just kidding. Okay, laying you on your side. Well, you're going to get the sacroiliac, but what about everything else? Do you want to adjust everything else above that? Or do you have a specific technique like Dr. Roger has that it can get a sacroiliac or get a hip when you're laying on your side and not disrupt the rest of the spine? And this is just what I think doctors of chiropractic can, if they go to a doctor of chiropractic and be that kind of scientist with their brain and engineer, it's magnificent what we can do together in helping people. Yeah. Now let's check your neck. Come on up.
Let Brian do that first.
Yeah.
Brian, come on.
You ready?
Yep, right.
Dr. Voytecek? Okay. Now, we want to test the cervical spine. Everything else is corrected here, but he's out of alignment here. We opened it up and did the occipital sacral release, okay? And if y'all know Dr. Garner, you know we have to get his head straight, all right? Poor guy. Okay. Look up. I'm isolating the first and second cervical vertebra. Turn left. Turn right. Turn left. Am I getting a restriction one way or the other? Doctor?
Yes, to the left.
To the left. Okay, now let's do cervical 3, 4, and 5. I know you all do cervical range of motion, but you incorporate different vertebral levels at different angles of the head tilt. All right? C3, 4, and 5 neutral. C3, 4, and 5 significantly restricted to the left. Okay? Head down. Turn left. Never mind. Turn right. Well, Dr. Garner has a significant rotation restriction in left cervical rotation. Okay? Does that have anything to do with what's happened and what we found below? Well, of course. Did we fix the occiput? We did. But the balance in the occiput and the sacrum, the technique we use isn't enough to fix everything. Okay? So let's go other techniques. Sternoclavicular joint, high on the left, low on the right. Okay, is that apparent? Okay? Tender? Tender? Yeah. Yeah. All right, and then we look, we have an elevated rib on the left, lower rib on the right. All right? Scapula, you don't have to see this, but it's a high scapula on the right. The scapula on the right is about almost an inch higher than the scapula on the left. So we have to balance something out here. But before we do, thank you, doctor. Let's see if gravity is having anything to do with this. Wedge, 1 to 2 inches on the right. I'm elevating his right pelvis, which changes his sacrum, which changes the rib alignment, okay? And it just even out his scapular borders, okay? And we can turn him around and show this, okay? Now, look up, and turn left. Turn right. Tell me.
Feels better.
Huge increase in range of motion by putting a wedge. So I'm confirming what I already know about upright structural alignment, even in the sitting position. By putting a wedge in the pelvis, it changes the range of motion. Chiropractors, would you rather try to adjust Jeff's neck, Dr. Garner's neck, this way? Hurt?
Yeah.
Yeah. Or would you rather have the help of gravity and body alignment where you can go like this and it comes all the way over and says, ah. Okay, now let's go C3, 4, and 5, increase. Let's go C6, C7, increase. Perfect. Okay? Doctor, you want to do the adjustment? Okay, very specifically.
Yes, so I'm going to go after occiput C1, C2, and that's going to be more as in looking up to the ceiling there. If I want to go down lower, I'm going to flex the spine, and that's going to get down to the lower cervical spine. So I'm going to do the upper cervicals first. And it's not a twist. You're going to see that. It's just the fingers. You'll see my fingers twist, and just jerking my fingers is going to be real short. Exit, like that. Not much with that. So I'm going to go down on the right side here. Again, on the lower cervical spine, I'm going to bring him down. That's it. It's not a dramatic rotation of the spine. Okay, look up. Turn your head to the right, to the left. So, mid cervicals, looks a great improvement on me. Look down. That's, I can't get any better now.
Perfect, thank you. Now, he took the wedge out, and now the range of motion is 100% acceptable, okay? Okay, face me, and just turn around here. Interestingly enough, scapular borders corrected themselves by adjusting the cervical spine. Really? Well, of course. With all the muscles that are attached from the shoulder girdle to the neck to the thoracic spine, by fixing the cervical spine, balancing everything out structurally, everything is shifted, okay? The sternoclavicular joint has changed. I just wanted you to see where this was way off before, the lower borders of the scapula, they're now even, just from doing the neck without touching the scapula. Now face them again, please. I know I should have showed you before, have to believe me. I showed you after, I didn't show you before. All right. Now, sternoclavicular joint. The left sternoclavicular joint was significantly higher before. What do we have now, Doc?
Pretty even.
Pretty even. So, your sternoclavicular joint's out of alignment, your scapula's off, let's just pound this shoulder. Whoa, time out. Do first things first. That's the order you talked about. In what order do you do things? And the feet, since they attach to the floor, we want to do them relatively first, because that's your foundation. When you get up further with the ribs and scapulas and shoulder girdles, keep doing the spine and balance it, and then you see they kind of correct the extremities, the outer portions. Again, it just sort of happens that way. I don't really see anything else, Doctor. Anything else bothering you? You're good. All right.
Thank you.
You're welcome. Dr. Gardner from Texas. Now, you can ask questions like anybody, talk to Jerry, email us, YouTube, whatever.